Now, it took a bunch of years, but we now know that that's not the best practice. Hello and welcome to this edition of Ask the Doctor. As a sub-series in our Wise Medical Minute, we want to respond directly to questions that have come from our patients. And we got a question this week about discontinuing Suboxone when you're admitted to the hospital for surgery. Now, when there's an accident or if there's some unrelated procedure where there's going to be some pain involved, traditional wisdom has been for years that you should discontinue the Suboxone. In an emergency kind of setting, that is not possible. And even in an elective kind of situation, we now know better that that's not appropriate. Now, the use of buprenorphine products has been going on since around 2000, and somewhere around 2004, the Health and Human Services people sent out a memorandum indicating that when people are admitted for some cause of acute pain, that they should have their medication like buprenorphine discontinued. Now, it took a bunch of years, but we now know that that's not the best practice. But the problem is, people who work in the hospital setting need to understand a little more about how buprenorphine works. Now, it is true that buprenorphine has a high affinity to what they call mu receptors. Mu receptors are what keep people out of withdrawal, okay? If those receptors are bound up by the drug when they would otherwise be recovering from, withdrawal from heroin or pain pills or whatever else we're preventing. Now, the people who have an acute source of pain, whether it be related to trauma or elective surgery or dental work, whatever, the bottom line is if you maintain the buprenorphine dose at a level that has been previously to prevent withdrawal, you can add even the full agonist pain medications on top of that to deal with pain. Now, because buprenorphine only binds to the mu receptors primarily, not only, but primarily, there's lots of other receptors in the brain to which the other opiates can still bind. So the pain relief is still achievable if you insist on using a narcotic. Now, when people have been detoxed off of heroin or pain pills, it's amazing how effective all of a sudden non-narcotic pain medication is when you have to treat a legitimate source of pain. There was a time in everyone's life when they had these opiate dependency issues, when they were wrestling with pain from withdrawal. Pain from withdrawal hurts, and it's real. But organic pain from some pathology or injury still responds to acetaminophen and ibuprofen and lots of non-narcotic options. In a hospital setting, they can use injections like ketorolac. But you don't have to use narcotics, and you don't have to stop the buprenorphine product, Suboxone or whatever brand. But you have to understand that if you use these other agents, it needs to be above and beyond the maintenance dose that the patient was on. Now, the other thing that you have to understand is buprenorphine in and of itself is an effective pain medication. And it's not unreasonable in the acute pain setting to use extra doses of buprenorphine. And you won't disrupt the whole detoxification process that the patient has agonizingly been through, and their fear of these other drugs to which they were previously addicted, or probably still are addicted, they can be managed with extra doses of buprenorphine and avoid that angst. Now, one of the things that also is necessary to understand is when you have been through a detoxification process and you're no longer as opiate dependent as you were once upon a time, that the dose required to get a given response from a full agonist is going to be less. So giving the same dose you used to tolerate might be enough to cause an overdose. So you do need to be conservative with the dosing if you use the full agonist concurrent with the buprenorphine. Now, there will be occasions when the anesthesiologists or the surgeons will insist that the buprenorphine products be discontinued so that they can use the full agonist that they're comfortable with. If that's the case, and if the buprenorphine is stopped at some point, whether in the hospital or soon thereafter, when it's resumed, it's important to make sure that there's a reinduction, preferably observed, enough hours after the last dose of the full agonist opiate. Now, the biggest mistake is if they use something long-acting as the source of analgesia when they take people off their buprenorphine. So if you're one of these folks on Suboxone, and there's millions of them out there now, you can share this video with your healthcare provider that is afraid to manage you with the buprenorphine and the other narcotic analgesics. There is a little more in the way of explaining dose equivalents and morphine equivalents and all that kind of stuff that's beyond the scope of this video. But if you have an encounter with a surgeon or an anesthesiologist or just a family member that is concerned about you going through acute pain and having had issues with opiate addiction, have them call me or write me, info@wisemedicalcenter.com, and I can put their mind at ease and give them a little inside information and talk technical terms and dosing even to make it easier for you to get proper care while you're experiencing the acute pain issue. Thanks for your attention, and I look forward to the next Ask the Doctor.
Thank you for listening to the Wise Medical Minute with Dr. Thomas Locke. Dr. Locke addresses current events as well as important medical issues using responsible, unbiased journalism approached from a medical perspective. We invite you to submit questions or comments or suggestions for future topics by email to info@wisemedicalcenter.com. Again, thank you for viewing the Wise Medical Minute.